Right. Over to you, Jill.
Thank you so much. Welcome, everyone. Thank you so much for attending Adapted Baby-Led Weaning for babies with Down syndrome. I'm really excited to present this information to you. I have been using this method actually since 2010, and I have seen incredible, incredible therapeutic benefits from offering solid foods to babies with Down syndrome by using this approach, and I'm really excited to present this to you today. And obviously, there's going to be plenty of time at the end for questions. So I did want to say, just a disclaimer, that the content of this webinar is not a substitute for you following the medical advice of your medical providers and for your advice that you're being given by your therapist, your speech pathologist, your physical therapist, etc. So everything I'm showing you is for your knowledge, but every child is going to be very, very different. And especially with this approach, very often you are going to need the guidance of a good feeding therapist to make sure that you are offering the size, shape, and texture of food that is appropriate for your baby's skill level. So just a little bit about me. I am a pediatric speech pathologist and international board certified lactation consultant. I am here in the United States. I am outside of Chicago, which is in the middle of the US, and I have been working with infants to 3-year-olds for over 38 years. I've worked in 3 different area hospitals here, and I now have a private practice where I see a large majority of children with Down syndrome. I would say probably 85% of my caseload is babies with Down syndrome. I often start working with families prenatally if they have a prenatal diagnosis, helping them get ready for breastfeeding and just educating them about what they can do to help their baby with Down syndrome. I work in our early intervention system here where I see lots of babies, working first on breastfeeding and bottle feeding, then helping them transition to solids, and then working on speech and language development. Back in 2010, I created the Adapted Baby-Led Weaning approach, which you're going to learn about today. And I co-authored a book called Your Baby Can Self-Feed Too, which was published in August of 2022. And I co-authored that book with Jill Rabin, who is the pioneer of baby-led weaning and comes from the UK. So I know that many of you probably already know what baby-led weaning is, but I just want to kind of just go over it quickly for those who may not understand what this approach means. The term baby-led weaning was coined by Jill Rabin, and as you know, since many of you live in the UK, as this is just a method of introducing complementary foods where babies are feeding themselves from the onset of beginning solids. Here in the US, when we use the word weaning, it's generally meaning weaning from breastfeeding. We don't use it in the same way that you do in the UK. And I did want to say that there's a lot of social media platforms that will say that if you're doing baby-led weaning, that we're anti-spoons and we're anti-purees, and that's absolutely not true at all. But as baby-led weaning advocates, we don't believe that any baby has to be fed by spoon by someone else. We believe that all babies can feed themselves. And we also don't believe that you have to buy any special made puree at the store to feed your baby. We feel that you can take any table food that you're eating and mash it appropriately so it's safe for your baby to eat. So I did want to make that clear that we absolutely use spoons and purees all the time, especially when we are working with babies with Down syndrome. So key features of baby-led weaning is everybody eats together. It's not like we feed babies earlier in the day and then we eat our meals later. Everyone eats together. We're offering all the different food groups from the very, very beginning. When we start offering foods, the baby in the beginning is going to be doing self-feeding using their hands. And we're actually going to offer them a lot of foods that are going to require biting and chewing. Although even in the beginning, a lot of the babies aren't really going to be able to bite pieces off or chew foods. It's just going to give them that gnawing experience. And you'll see that in some of the videos, what I mean. The baby is always the one in control. They determine what foods they're going to eat, how much of that food they're going to eat, and at what pace they're going to eat that food. And with baby-led weaning, it's a very gradual progression. We follow the cues of the baby. There's no specific schedules or stages. We often offer an open cup in the very beginning as well. We work on cup drinking right when we start solids. And what we find is if we really follow the baby's cues with feeding, they will naturally reduce their milk feeds on their own. So one thing I do have to say is that we know that baby-led weaning has become very, very popular among families. But at least here in the US, there's a lot of controversy about baby-led weaning, and a lot of the medical professionals, pediatricians, family practice doctors, they're very anti-baby-led weaning, and they think that it's dangerous. And they think that for babies that are exhibiting neurotypical development. So you can imagine their response when we say we would like to do that approach with someone who's neurodivergent, who has a diagnosis, or who may have feeding challenges. And I think what's really important is we need to educate everybody about this approach and that it can be done safely and that it can yield very therapeutic benefits, especially for children with Down syndrome. And we need to educate the feeding therapists. We need to educate the doctors, because what will happen is they're going to discourage you from doing this, and then you are going to be on your own trying to figure this out. And I will say that I am in the process of creating a class specifically for professionals. I already have one for parents, but I want to encourage anybody who has a feeding therapist who wants to do this approach with their baby for their therapist to take that class so they can be educated in how this works and how it can be done safely. So what exactly is adapted baby-led weaning, and how is it different from traditional baby-led weaning? So way back, I hope you guys can see this. Okay. Way back in 2010, when I was working with a lot of my clients, I would see a lot of babies with Down syndrome that were in their toddler years that were still eating only pureed foods, and they were being fed by an adult, not doing any self-feeding. I had learned about baby-led weaning from a colleague, and I had watched a little video about Jill Rabin's approach, and I was amazed by how these babies were self-feeding from the time they started solids. So what I did is I decided I was going to figure out how I could do this with my clients in a way that was safe, and that is how adapted baby-led weaning got developed. And like baby-led weaning, adapted baby-led weaning follows all the same principles of traditional baby-led weaning. We just have some steps in between where babies might need a little bit more guidance until they're self-feeding like their peers. So with adapted baby-led weaning, we use what we refer to as bridge devices. And those bridge devices might be something called a silicone feeder, which you're going to see, which helps babies bring things to their mouth and helps them to chew safely. Or sometimes we do something called a preloaded spoon, which also serves as a bridge to teach hand-to-mouth skills. And we use some of those devices if the baby is struggling in picking up foods with their hands. In some situations, if the baby is very low muscle tone and they're struggling a bit with those hand-to-mouth skills, we might have to help facilitate bringing hand to mouth. Obviously, always following the baby's cues and not trying to force or push something into their mouth if they're telling us that they don't want it. We use those bridge devices again until those babies start to use their hands to self-feed. We also will sometimes use those bridge devices for babies who might be more tactily defensive and don't like to touch things or get things on their hands. So the difference between the adapted baby-led weaning and the traditional baby-led weaning is we might have to do some facilitation to help bring hands to mouth, and we might need to use some of those devices to enable that baby to self-feed. What's great about the approach is it's completely child-directed. If a baby is breastfeeding, it's going to allow them to breastfeed for a longer period of time because they are the ones who are determining how much food they take in versus someone else dictating it to them by feeding them baby foods from a jar or from a pouch. And obviously, baby-led weaning is a natural follow-up to breastfeeding because breastfeeding is also a child-directed feeding approach where the baby determines their own hunger and satiation. What we find with babies who do this approach is they tend to like a larger variety of foods because they are more in control and they tend to eat more table foods as a result. And also, they're getting exposed to textured foods very early on. We do know that a lot of the research supports that if babies don't get exposed to textured foods in the first 3 months of being introduced to solids, it can increase the likelihood of them having some feeding aversion and picky eating behavior. So, in terms of therapeutic benefits of this approach, there are many. And I think what's amazing is all the hand to mouth work. These babies are constantly picking things up and bringing it to their mouths. So they're engaging their core, they're working on their eye hand coordination. If babies are picking food up off of their tray, they're learning to gaze downward and readjust their vision. If someone is feeding them with a spoon, their visual plane is going to stay the same. That the spoon is always going to come in the same direction at the same angle, and they're not going to learn to use their vision down and readjust it looking back up. So it's really working on a lot of skills. It also works on something called midline orientation. Many babies with Down syndrome tend to favor one side of their body or the other, and they have trouble integrating both sides together. When we do a baby-led or adapted baby-led approach, we tend to use a lot of bigger foods, which encourages two hands together in the middle of their body. So a lot of these babies don't even realize that they're doing something therapeutic. They're just very motivated by the food that they're eating, and they want to use their hands together in order to hold that food. With this approach, we see babies learning to self-feed much earlier, and there's also long-term nutritional benefits. And there's long-term nutritional benefits because they're learning to chew from the very, very beginning. So when you are doing more sustained chewing of food, you're using more saliva, there's more digestive enzymes, so you are going to better chew and thoroughly break down your food before swallowing, which is obviously going to be very helpful in terms of digestion. So when you're using real foods and a lot of the firm foods that we use with this approach, babies get something called oral proprioceptive input. So they get a lot of deep input and a lot more sensory input. So for example, it's a much different sensory input when you are drinking applesauce from a pouch versus biting and chewing a real apple. So they get a lot better feedback. We do a lot of strip-shaped foods for babies who do this approach. So they are used to using their jaw to bite up and down, and they're using a lot of side-to-side or lateral tongue movement when they're doing that, which is a pre-chewing skill. They develop excellent oral motor skills from the beginning because they're gnawing and chewing on so many different things. And what's lovely about the approach is they can literally sit and eat with the rest of the family while they're doing this. And the interesting thing about the way that we eat is it actually shapes our face. So babies who are breastfed tend to have more U-shaped palates because the breast actually shapes that upper palate and it allows more space for the teeth to come down and descend. Baby-led weaning does a similar thing. Because you are doing so much chewing and gnawing, like this little guy is doing here with celery, what happens is it really works on jaw strength and it actually increases the size of the jaw and can make a larger oral cavity, which is going to help with airway and airway patency. So how we eat actually has a really good and strong impact on babies' health as well. So the populations that can benefit from baby-led weaning and adapted baby-led weaning, I want to say really that all babies benefit from this just because of its child-directedness and babies determining when they're hungry and when they're full and all the skill development that takes place with this. Even if you have a baby with a very complicated feeding history, maybe your baby has a G tube or an NG tube, or your baby has some aversion to food, I can tell you that this approach will work for anyone. There's a little baby that you're going to see today that was in the hospital for the first 8 months of her life. She was on a ventilator for most of that time. She had a nasogastric tube and then she had a G tube, and she is one of the best eaters that I have. So, and I'll point her out when we get to her, but don't be discouraged if your baby does have a complicated medical history because it does not mean that they cannot do this approach. So how do you implement baby-led weaning when there are feeding challenges? So I do want to say that a baby with Down syndrome is going to need support. You're going to need a therapist who understands oral motor and feeding skill development so they can instruct you on exercises and things to do that you can work on long before your baby starts solids and then once your baby is eating solids. Sometimes what we do is we develop a pre-feeding program. So we use, like this little guy here is holding a yellow chewy tube. We will use those little devices to work on jaw strength and the tongue moving side to side. And we'll work on a lot of those foundational skills long before we offer food. Once we do offer food, we are going to pick the shape, size, and texture of that food based on your baby's skill and what skills we want them to learn next. So we will make sure whatever we're picking is safe, but that it's also going to work on feeding skill development. So Lori Overland and Robin Merkel-Walsh are two speech pathologists here in the United States that wrote this book, A Sensory Motor Approach to Feeding. Lori Overland lectures quite frequently on Down syndrome and her sensory motor approach. It's an excellent approach. I use this book quite frequently as a reference, and I do some lectures together with Lori, and we combine her sensory motor approach with adapted baby-led weaning. And what she does with her approach is she task analyzes every type of feeding. So for example, she has all the skills listed that a baby needs in order to breastfeed successfully. She evaluates the child and she sees what skills are missing or that need help. And then she works on different exercises and on ways to make those skills stronger. And she does the same thing with solid food feedings. She will develop a pre-feeding program in those first 6 months, long before the baby gets solids, to work on those underlying motor skills. And then once the baby is eating, again, she will also use different tools and different shapes of food in order to facilitate certain feeding skills. And I'm going to show you a video in a little bit of what therapeutic feeding might look like. So when we are working on skills with babies with Down syndrome, we are going to be addressing the jaw, the tongue, the lips, and the cheeks. Lots of people don't realize that the cheeks have a lot to do with eating. If you have an open glass near you and you take a drink, you cannot suction the liquid out of that open cup unless you are engaging your cheeks. So we're going to address all those areas when we do these programs. Sometimes what we do is we use this thing called a Sensi kit that has lots of different tips and things that facilitate different movement of the tongue, lips, jaw, and cheeks. And sometimes we use those little chewy tubes on the right also to facilitate some of those skills. So when should we begin baby-led weaning or adapted baby-led weaning? We want to start at 6 months or later. That's when the World Health Organization and here in the States, American Academy of Pediatrics recommends to start solids. But in some situations, when babies have more delays in their motor development, we might need to wait till 7 or 8 months, and that is absolutely okay. It's much more important to make sure that the child is ready and not to focus on age. But I will tell you, when I start with babies as infants, and I do a lot of that pre-feeding work, most of my babies with Down syndrome are able to start doing solids at 6 months of age. With the first 3 months of this approach, it's really more about learning skills, and it's not about volume of intake of food. Breast milk and formula are still going to be the primary sources of nutrition. And I think that when we're not concentrating so much in those first couple of months on volume intake, it takes a lot of the pressure off of the parents. So, and I also wanted to stress that the diagnosis doesn't define the person defines the diagnosis. And I'm sure that some of you may have experienced this already, that sometimes the medical community and the therapeutic community, they just see the diagnosis of Down syndrome, and they already have a preconceived notion of what that is. And I think that it's extremely important to look at that individual baby, because just like neurotypical babies, everybody is going to be different. And just because they have a diagnosis of Down syndrome, and even if they've had a very complicated medical history, it does not mean that they cannot learn to eat using a baby-led approach. So some of the adaptations that we make when we do adapted baby-led weaning is we may need to start solids later than 6 months, depending on that motor development. In the beginning, when we start with food, we're going to be doing a lot of food strips, or what we refer to as food teethers. So we're literally going to use firm foods, almost like a teething toy for babies to learn hand to mouth skills. With this approach, we might have to help that guide that baby's hand to their mouth if they're struggling from a gross motor standpoint. We may need to start with mashed and pureed foods, and we might be stuck on that food texture for a while until the baby develops more skills. We might need to be using those bridge devices such as preloaded spoons and silicone feeders, which I'm going to be showing you very shortly. And again, we might be stuck, like I said previously, on the same food texture for a while until that baby develops better skill. And then what we will do is we will change the size, shape, and the texture of food depending on the skill levels of those babies. So really, the most important thing when you're going to start solids with your baby with Down syndrome is a good, stable chair. And one of the most important things is having a high chair that has an adjustable footrest. And these are some of the chairs that I like. I'm pretty certain at least the Nomi and the Stoke Trip Trap are available in the UK. And these are fantastic chairs. Yes, they are a lot of money, but they are a very, very good investment, because if your child is seated well and has good support in their feet, it's really going to help with their self-feeding abilities. If your baby is super tiny and they're struggling because there's a lot of space in the chair and they're tilting to the side, sometimes you can use something like this. This is called the high chair helper, or the therapists that are working with your babies can create something. Sometimes our therapists here create something out of styrofoam, or they use towels and blankets to make sure that the baby is seated securely in their chair. And you can see here, we want to see a 90-degree angle from hip to knee and then knee to ankle. So we want those babies' feet flat, if possible, on that adjustable footrest. This little baby here on the left, he is in the IKEA Antelope chair. If you cannot afford to spend a lot of money on a high chair, that is a very reasonable and excellent high chair. You have to purchase the footrest separately, but that is a great chair to use. And it's also a great chair to have at a grandparent's house. And these are just some examples. If you don't have a footrest on the high chair, I've had parents create them with a book, where we tape a book or a shoebox. This little girl's got a high chair helper behind her. In this one, we used a towel. I would say if you have to make a high chair hack, a footrest hack, you want to make sure it's firm so that baby is getting input into their feet. The towel is fine, but a firm surface is going to work a little bit better. So also too, we know, I already mentioned this earlier, it's really, really important to introduce textured foods. And when I say textured foods, an example would be if you took a banana and you mashed it with a fork, that it would have some texture to it. It would have little lumps in it. We want to make sure that these little ones are getting exposed to that type of texture very early on. And this research study showed that children who did not receive these lumpy or textured foods until after 9 months of age, that when they were tested at 7 years of age, that they were eating much less of many of the food groups. So you can see more pickiness with kids who are not exposed to textured foods very early on. So with adapted baby-led weaning, sometimes we're going to have a little bit of a transitional phase where we're really working on skill, and that baby may not be taking in a lot of food volume until those skills get better, where we're going to have to help facilitate hand to mouth. The baby may be touching and holding a lot of food, but not eating and swallowing a lot of food. We're going to be using a lot of those food strips as teethers. We might be using smooth and textured purees on a preloaded spoon. We might put foods in a silicone feeder so the baby can hold the handles of the silicone feeder and learn to chew. We are always going to be responsive and watch the baby's cues when they're telling us they're all done. We respect that. And again, sometimes when babies are struggling a little bit with their gross motor skills, they may get stuck in the transitional phase a little bit longer. But again, with time and practice, they're going to be able to transition out of it. So these are some of the bridge devices that we might use to work on hand-to-mouth skills. This is an example of a silicone feeder. It almost looks like a little pacifier with this little pacifier ending with holes in it that the food comes out of. These are weaning spoons. And if you notice, the bowl of the spoon is very flat. That's intentional because this is a spoon that's not supposed to be used for scooping. It's really used as a means of helping that baby get food to their mouth. And it's a lot easier to remove food from a flat bowl of a spoon than a spoon with a deep bowl. And these are tiny pops from Easy Peasy. I don't know if you have Easy Peasy in the UK, but these are little popsicles. They have these tiny little handles, and this is a breast milk popsicle, but you can make any kind of food popsicle. And that's a great way to work on hand-to-mouth skill for the baby. So here's an example, and I'm going to show you now how I might take a baby with adapted baby-led weaning through the process of teaching them to self-feed. So here's an example. This is Hudson, who's probably around 8 months in this video, and he's doing a food popsicle. So you can see it allows for hand-to-mouth skills. It's great for teething. And you can really make those popsicles out of anything. You can use coconut milk and avocado. You can make them caloric, but it's a great way to work on self-feeding. And then one of the first steps that we do, in addition to strips, which you'll see a little bit later, is we do preloaded spoons. So we take a food like an avocado or a banana or a sweet potato, we mash it, we stick a spoon in it, and we hand it to the baby, and the baby feeds themselves.
Something new. Oh.
And what I love about those spoons too is it encourages some chewing behavior.
So she tried out for, she has a.
So you can see that the baby's the feeder. We use spoons and purees, but we are not the ones feeding. We give it to the baby and they feed themselves. Once the baby gets really good at bringing the spoon to their own mouth, when we hand it to them, we then advance it a little bit and we start to put the preloaded spoon on the tray. The reason we do that is we're training the baby to use their vision downward to pick it up, because pretty soon we're going to start to put food on the tray and pieces of food on the tray so they can pick it up themselves. So here's Millie. Millie, this is the little girl who spent the first 8 months of her life in the hospital on a ventilator and who had a G-tube. So you can see her picking it up, and then she brings it to her own mouth. And again, you can see it's easy to get the food off because the bowl of the spoon is flat, and she can bite on it as well. So once the baby's really, really good at picking up the spoon off of the tray with the food on it, we then just put the mashed food on the tray and we don't need to use the spoon anymore, and the baby uses their hands. So at first they're going to use their whole hand and do a raking motion and eat the food off of their hands, but over time they're going to start to use all of their fingers, and then eventually they're going to start to use just their pointer and their thumb. And when they start to do that, we know that we can start to move to pieces of food. And yes, this is very messy, but this is a great way to work on self-feeding skills. And you can see at this point too, that babies are really starting to take in a lot more volume. And this is Rose. And even when we put food on Rose's left side, she always reached across and always used her right hand. So that's next up. And that's actually quite a hard skill to teach babies. It takes them some time, but you can see it's really getting her to use her vision because she has to look down to see the food and then to bring it to her mouth. And now you're going to see Sophia doing the same thing with avocado. And you can see it's textured, and you can also see again that she's also getting lots of volume. So she's now already starting to take in more food. So those are examples of mashed textured foods. So here are examples of silicone feeders, and you can see they have the little handles and the food's inside. The reason we use these, sometimes we use them if a baby's struggling to hold a food and it's too slippery, so we put the food inside of it. But what we also do is we use silicone feeders as a bridge to chewing. And what that means is we start off with something in there that when the baby bites on it, it comes out easily. Maybe we put banana in there or avocado, but as they get a stronger jaw, we might put strawberry in there, and then eventually putting in chicken and meat to really work on jaw strength. And so you're going to see Rose with the silicone feeder, and you can see her really working on her chewing. And this is one of those bridge devices that I was talking about. And then you're going to see this little one who's still learning to eat. She still had a nasogastric tube in. You'll see her self-feed avocado. And you'll notice when she pulls the silicone feeder out of her mouth, she's already chewed enough. She's cleaned the whole feeder out just from her chewing skills. And you can also see how it's encouraging her to use both of her hands together in the middle of her body. So those are silicone feeders. And another thing that we use as a bridge is frozen straws. So these are silicone straws that are cut in half. And what we do is we fill them either using a syringe or by stretching the end of the straw over the nozzle of a pouch. And we fill that straw and then we put it in the freezer. It serves as a great strip for babies. They can really work on their chewing skills. You can use it resistively where they can kind of stretch it. And then between their chewing and the warmth of their mouth, it releases the food from the straw and they get rewarded for their efforts. So this is Graham doing it.
Munch, munch, munch.
And his mom's
I
asleep
like how
about
you're using
this.
both sides. How you're going back and forth. Is it?
And they're also great for teething. And then you can see this little guy doing the same thing. And you can see how it's really nice. They place it on the side. Their tongue goes to the side. They're using their jaws. They're working on chewing. So again, another great bridge to chewing skills. And you can see that some of it is starting to drip out of his mouth because it's starting to melt. So just some ideas of ways to work on chewing with those bridge devices. And these are just some examples of therapeutic feeding. So these are actually from yesterday. I just put these in for you to see. This is Leandro, and we're using something called a netted feeder. So it's a little netting, and we've put a piece of orange in there. We twist the little netted feeder, and we place it on his first molar to target sustained chewing. You can see his mom's placing it there. And we're just kind of getting him to chew for a longer period of time on his first molar area. And I tend to use a juicy food when I do that because then they immediately get rewarded for their efforts. And then now in this video, we're doing something called therapeutic fork feeding. We're using small pieces of banana. We're having him help hold the fork, and we're placing that piece of banana on his first molar area to get him to chew it versus just swallow it. You can see we place it on that first molar, and what we're working on is getting him to chew up and down. So it's a great little therapeutic feeding tactic. So he's getting to eat, but we're using those things therapeutically to work on a skill. So we also, in the beginning, in addition to preloaded spoons and all the other things that I showed you, we use a lot of strips, firm food strips, or what we refer to as food teethers. And these are great because they're easy to hold. Babies can work on bringing it to their mouths. They can explore all different types of tastes. They can do a broccoli stalk. They can do asparagus. They can do a rib bone. And what's great about it is it really works on your jaw strength. It works on that side-to-side tongue movement. And with some of those food teethers, pieces cannot come off in the beginning because babies don't have enough jaw strength or teeth to break anything off. And we can really work on skills without worrying about your baby choking. And so this is about the length and the shape that we'll cut the strips that we use in the beginning. And you can see on the left, all of these strips on the left are usually safe for babies who are just starting to do this approach and who do not have a lot of jaw strength and teeth yet, because they can just use those as a food teether. However, once those babies get stronger and you start to hear crunching on some of those foods, or you're afraid that they're going to get pieces off, then we switch and we go over here to the right side and we do true food teethers. True food teethers don't yield any pieces. You can gnaw on them and chew on them, but pieces are not going to come off. So examples of that would be a rib bone, a mango pit that we peel all the flesh off of, a pineapple core because they're just going to get the juice of the pineapple, and then a corn cob that doesn't have the kernels. And there's actually, I actually have it on my Amazon storefront. There's a little device that actually can pull all the kernels off of the corn cob. And again, like I said in the beginning, sometimes we have to do facilitation where we have to hold the baby by their elbow or their wrist and actually help guide that food strip to their mouth if they struggle doing it themselves. And this is an example. This is Bodhi. Mom had sent me this video during the pandemic. She actually cut she's using a baby carrot, which is too small, and that strip needs to be a little bit longer, about the length of a crayon. But what I want you to see is how she helps facilitate bringing it to his mouth.
Hi, sweetie. Yeah, we love eating. We love it. We love exploring food. Let's try it. Let's bring that to your mouth. Here, let me assist. Let me assist. There we go. There we go.
And you'll see he's trying to get it. She helps him.
Almost. Good job.
But it was just a little too short. But that's just an example of how you would help bring it to the baby's mouth. And then here are just some examples of children using foods as food teethers. This is Hudson with the celery stick. And what we can do with those as well is we can dip them in. We can dip it in yogurt. We can dip it in hummus. So we could use those as a means of offering food as well. He likes the way it feels on his gums, but you can tell his jaw is getting a little bit stronger. And then you can see Teddy here is using a very toasted bagel as a food teether. He's not able to get pieces off. And what's great about this food is he's using both of his hands together in the middle of his body. And you can see all the jaw work that he gets just by gnawing on a food like this. And if we get nervous and we see lots of pieces starting to come off, we might have to move away from a food like that until the baby has better skill to chew. But in the beginning, it's a very motivating food for them to work on hand-to-mouth skill. Here is Teddy with a corn cob. His mom didn't do a great job of removing all the kernels, but you can see how he can hold that himself. And even with the kernels off of the food, you still get a lot of taste. It's still very sweet and babies are really motivated by it. And you can also even put some butter on it. And then here, this is Tiago, and he's doing a pineapple core. And when he gnaws on it, he's getting a lot of jaw work, but he also gets the juice of the pineapple. And now I'm going to show you, this is another Teddy, and he's doing broccoli on the stalk that he loves. And you can see again that the stalk is like a built-in handle, and you can gnaw up and down. You can dip the edge of that steamed broccoli tree into olive oil for some more taste. We sometimes do olive oil and then dip it in nutritional yeast. So that's another example of a food teether. And then you're going to see Teddy again with a rib bone. And again, you can see that nice hand-to-mouth skill and the work that he does with his jaw. And you can leave a little bit of the meat on there for the taste. Again, another very motivating food for babies, and it's also a great source of iron for them. So just some examples of food teethers. Here's a mango pit. This little guy's holding one. This is Tiago gnawing on a mango pit. which can be very slippery. But again, we've taken most of the flesh off of it, and we can hold it and taste it.
Amor? Es delicioso el mango, ¿verdad? Qué rico.
As you can see how slippery that is.
Bravo.
So something that we do sometimes is we have a little device called a Frida baby holder. It's actually meant to hold like cold teething things, but one of the moms whose little girl that I work with figured out that the mango pit fit in there, and you can see now she can hold it and it's not too slippery for her. I've even had parents put it in a baby sock and they hold the sock. So just some ideas if the mango pit is too slippery for the baby. We also can do meltable solid foods, and every culture usually has one of these meltable solid foods. These are foods that if you take a bite off of them, they'll usually dissolve in their mouth like a rice rusk. And you can see Evan is doing one here. And these are great foods to work on hand-to-mouth skill and also to work on jaw strength. And what's great is if a piece does come off, they dissolve readily, so it's not a choking hazard. So those are really great foods to use. And I use them a lot therapeutically with babies to work on chewing skills, as I know that they're pretty safe. And then in a second, I'll show you him with another meltable solid. Here he is with another one. And you can see the nice jaw work that he's getting there just by biting up and down on it. I generally like that shape of a meltable solid the best to work on chewing. And then the most advanced strip that we do are what we refer to as resistive strips. And those are strips that the baby, when they grip it with their gums or teeth, the food stretches and it yields a piece, and they have to be able to chew the piece that comes off. And that's a pancake. And you can see that he can grip it with his hand, and then he bites and pulls pieces off, and that he's able to chew it. And this is usually after the child has been eating for some time and has developed good enough skills to be able to chew. And you can see it's resistive how he bites and pulls it off. So that's one resistive strip. And now I'm going to show you, this little girl has a mozzarella stick, and you're going to see her bite and pull and use this resistive strip. So she bites it and she pulls it. So another example of resistive. And again, those are more advanced foods. And what we need to do sometimes is if we give a baby a pancake strip or a waffle strip, they try to push the whole strip into their mouths. So sometimes we need to kind of use therapeutic feeding to teach them to bite and pull. And you can see here, Evan's mom is helping him to grip and then pull the food because he had a tendency to try to push the whole thing in his mouth. So we worked on that skill with him using a pancake strip. And then also we use really big foods where we peel them. And you can see here that he's eating that food, just mostly tasting it. He's not getting big pieces off, but it works on nice little graded movements of his jaw. So it's very therapeutic. And then here he's eating a guava. And again, it's working on both hands together. It's working on jaw strength. It's working on chewing skills. So lots of these foods are working on many different skills at the same time. And with a lot of my patients, they're always eating family foods. Oops. Let me pause that for a second. So now I'm going to show you, this is Marjorie, and you're going to kind of see her journey and kind of what that might look like with adapted baby-led weaning. just an example of what that might look like over time. And again, so some of the foods that we're going to do with baby-led weaning, we like to introduce lots of different colors. So if there's purple sweet potato at the store, we want to expose that baby to lots of different colored foods, green foods, orange foods, purple foods. These are just some examples of how we would cut food into strips. This is papaya, watermelon, and this is a carrot. And we used a crinkle cutter that creates all these little divots, which makes the strip a little bit easier to hold for the baby. This is delicata squash, and this is just a really toasted baguette. That's not only is it great to use as a food teether, but it also exposes the baby to the allergen of wheat. And the very cool thing is we can do one food in many, many different ways. So in the very beginning, when we're first starting, we might first do the preloaded spoon with mashed banana. Then we might do a partially exposed banana where the baby just gnaws a little bit. Then we might do a strip like this that the baby can take bites off. Then we might put a piece on a fork to work on that therapeutic fork feeding. And then we might work on our pincer and our chewing skills by the baby picking up those pieces of banana from the tray. And we can do lots of different offerings and different ways of many, many different foods. And these are just some examples of pieces: quiche, some hard-boiled egg, lentils, and avocado. And sometimes I will use these partially exposed foods where we take a big food, encouraging that baby to use both hands, and we peel it a little bit so the baby can hold the peel part without it slipping. And we can do that with an avocado. We can do that with a kiwi. We can do that with an orange. And again, you already saw we can do that with a banana. And I'm just going to show you here. Here's an example of what that might look like with the orange. And this little girl, this is when we were weaning her from her G-tube. And sometimes she didn't want to use her hands and would want someone to hold it for her. And then this little girl needed a little help at first to pick it up. But then when she figured it out, she was able to, we put it in that cup to make it easier for her to pick up. And that again works on both hands, works on the jaw, and you're going to see she's going to pick it up by herself. And I promise we are almost done. So just some examples of how we use those partially exposed foods. We always do open cup drinking. So often I use more of a nectar consistency liquid, but Bodhi was pretty good with the thin liquids. So we want to work on cup drinking from the very beginning because that's going to work on a lot of skills. And we're going to, you can see these are all little ones. This little guy's 18 months with Down syndrome. And he can drink independently from the straw cup, from the open cup. And using sometimes a thicker liquid, like I said, like a nectar consistency is more helpful. And you can hear him using those cheeks for suction. Usually the hardest part is placing it down and not throwing it. And then you'll see here, I'm going to advance to the next one. You'll see this little guy doing a smoothie texture with his.
Smoothie.
I do like those cutout cups because then you can see the liquid going in. You can see, and he's 2 in this video. And then you can see, this is the consistency I like the liquid to be. So when you tilt it, it goes to the edge, but it has a little bit of slight thickness to it. So just some examples. And again, straw cups. I usually start with the honey bear because you can squeeze it and help the baby to draw the liquid up by squeezing it. And then once they learn to drink by themselves, we want to work towards a regular straw cup that doesn't have a valve. Then the baby can do it all by themselves.
Can you show me? Drink. You show me. You do. Good job.
So just some examples of those. And just some resources for you. This is the book that I wrote about this approach. One of the best things about it is there's an insert inside the book with all the pictures of all the different things that we discussed and how to facilitate those skills. I was on a podcast called the BLW podcast by myself and with Jill Rabin that talks all about the approach and how it's therapeutic. And then I don't know how many of you are familiar with the podcast, The Lowdown. I was also on the podcast talking about the approach there. So those are some things to listen to get some more information. These are the different ways that you can contact me. If you do follow my Instagram, you will see that I have a lot of videos of how I do this with children with Down syndrome that can kind of help guide you if you're not sure where to begin. In this, I do have an Adapted Baby-Led Weaning class for parents available on demand. Sometimes I do it live on a Saturday, and you can scan this QR code and it takes you to that class. It's an almost 2-hour class. It's very, very thorough with a lot more detail than I gave today that teaches you if you don't have someone that can guide you. And this is just a QR code for different feeding resources on my website and a lot of the things that I talked about today. If you needed some information about some of the things that you saw.